which is joints, a group of diseases زي ما هنشوف. They are grouped together. They are heterogeneous conditions, but they are grouped together because they share common etiopathogenetic and clinical manifestations زي ما أخذتوا في المحاضرة. زي ما هنعرف musculoskeletal sites of the synovium يعني بيحصل synovitis, enthesitis, وكمان بيحصل extra muscular or extra articular targets such as the uvea, بيحصل uveitis and aortic valve root بيحصل inflammation يعني بيحصل aortitis. طبعا في المحاضرة قلنا that we group them together because they share articular, extra-articular and genetic features. There is a strong predilection to the spine. Affection of the spine is common, especially the sacroiliac joints. بنقول برضو that they are often associated with HLA-B27 وفي familial tendency بيبقوا negative for rheumatoid factor. عشان كده زمان كنا بنقول عليهم seronegative spondyloarthritis. These are the groups of the diseases. The most important disease that you should know as undergraduates اللي هي ankylosing spondylitis. But we need to know that we also have psoriatic arthritis, reactive arthritis, arthritis that is associated with ulcerative colitis and Crohn's. وطبعا عندنا برضو في الأطفال الجوفنال والundifferentiated مش مهمة قوي بالنسبة لكم. يبقى the important clinical subsets اللي هي ankylosing spondylitis, psoriatic arthritis, reactive arthritis including Reiter's, enteropathic arthritis والundifferentiated. وإيه اللي بيجمع كل دول مع بعض؟ اللي بيبقى فيه low back pain. وإيه السبب low back pain؟ sacroiliitis. In the clinical approach, it's very important to take the history. From the history, you will be able to reach the diagnosis زي ما قلنا المرة اللي فاتت. You have to ask about the onset and the duration of the symptoms. You have to take a detailed history of the low back pain. Is it inflammatory or non-inflammatory? Is there morning stiffness? The duration of morning stiffness? في peripheral arthritis ولا لأ؟ في enthesitis. أسأل على heel pain وأسأل about the extra articular manifestations يعني أعمل review of systems. For example, the peripheral arthritis زي ما احنا شايفين هنا في الصورة ممكن يحصل ايه peripheral arthritis of the knees and تبقى عادة ممكن كمان تبقى زي شايفين احنا هنا unilateral arthritis of the knee. دي بتحصل في ايه في بعض الحالات peripheral spondyloarthritis. برضو الانثيسايتس زي ما احنا شايفين هنا احنا قلنا what is enthesis? This is normal, the site of attachment of a tendon of a ligament to bone. هنا برضو حصل inflammation of the enthesis, enthesitis, quite common in the spondyloarthritis. People having axial arthritis لازم دايما أسألهم عندك وجع في كعب الرجل ولا لأ. يبقى أكتر حالات axial spondyloarthritis عشان ما نقولش معظمهم بيبقى عندهم inflammatory chronic low back pain. We know that back pain is a common symptom. كلنا بيجيلنا. But what is inflammatory chronic low back pain? Usually the age of onset less than 40 years. Gradual insidious onset. مش زي الميكانيكال. شال حاجة جاله مثلا disc ده بيبقى sudden or acute onset. It improves with pain. يقول لك my pain gets better when I walk. It gets worse when I am inactive, when I rest. Especially at night, I get pain, nocturnal pain, and I have to get up. If we get at least 4 of these 5, we are allowed to say that our patient has got inflammatory chronic low back pain. يبقى نفس الحاجة بنقول هنا morning stiffness, worse with symptoms, and its duration is chronic. برضو نفس الحاجة اللي احنا أخذناها في المحاضرة. قلنا ايه هي الحديثة الكرايتيريا الحديثة اللي نشخص بيها الاكزيال spondyloarthritis اللي هي الاساس كرايتيريا for the classification of axial spondyloarthritis. برضو ايه هي اهم حاجة بنقول in any patient having chronic low back pain يعني ايه chronic more than or equal to 3 months and his age is less than 40, أحط بقى أو فكر in two clinical in two arms. هقول الأول لو أنا هعمل له X-ray يعني not an X-ray I have to do imaging not a plain X-ray I have to do an MRI. If on the MRI I find manifestations of sacroiliitis then I need one more feature اللي احنا بنقول عليه one or more spa feature. الفيتشرز دي كلنا لازم نبقى عارفينها. ايه هي؟ There is a list of features. Number one, inflammatory back pain that we have just described, arthritis, enthesitis, uveitis, dactylitis, yani inflammation of the digits, psoriasis, Crohn's, or ulcerative colitis. When I give him non-steroidals, he gets a good response. Family history for SPA. Only my mother has psoriatic arthritis and my uncle also had ankylosing spondylitis. HLA-B27 is positive and an elevated CRP. Or I don't find anything on imaging, but he's got an HLA-B27, a genetic predisposition اللي احنا كلمنا عليها, plus 2 or more features. يعني مش بس واحد. We need, for example, enthesitis and dactylitis or psoriasis. So if we have more than 2 and HLA, we can also diagnose our patient. Also, we have something called, as you see here, either we need sacroiliitis on imaging, on MRI imaging, or if it's on an X-ray, we go according to what we know as the modified New York criteria. What is the modified New York criteria that we should know? Here we have clinical criteria and radiographic. What are the clinical criteria? نفس الحاجة, chronic low back pain and stiffness that is lasting more than 3 months, improves with exercise, is not relieved by rest. When I examine him, he's got limited lumbar spine motion in both sagittal and frontal planes, limitation of chest expansion, and the radiographic criteria, we require either bilateral sacroiliitis, لازم يبقى أكتر or equal to grade 2, هتاخدوا ده في radiology, or if it's unilateral, يبقى لازم يبقى أكتر من grade 3. If I get more than one clinical plus one radiographic, he's got definite ankylosing spondylitis. When you see your patient in the round or in a clinical round setting, in a clinical setting, you will find that we see our patients, it's quite common. We thought it wasn't common. It is common, around about 2% of the general population. It's also present in 2% of HLA-B27 positive population. And if a family member, if an individual is B27 positive, his affected family member has also a 20% chance of also having ankylosing spondylitis. So there is a strong genetic predisposition. The age of onset, زي ما قلنا, usually a young male patient. The male to female ratio is around about 3:1. So this is one of the autoimmune rheumatic diseases that is commoner in males. And as we said, inflammatory back pain, ولازم 4 of the 5 features that we have to always know. Age of onset, chronic onset, chronic progressive insidious onset associated with morning stiffness. What are the musculoskeletal features? We get also sacroiliitis, خلاص كلمنا عليها, and the spondyloarthritis. Don't forget about the enthesopathies, Achilles tendinitis, plantar fasciitis, asymmetric peripheral arthritis, and the associated tenosynovitis. What are the extraskeletal features? مهمة قوي. أي حالة, I ask him, have you got any eye complaint? For example, I know that they can get uveitis, conjunctivitis. Have you got any psoriasis, any bowel complaints, any genital urinary complaints? Because I know that we can get urethritis, balanitis. Any cardiovascular complaint, dyspnea, orthopnea, chest pain? Because I know I can get aortitis, pulmonary involvement, and renal impairment can also occur. So, in the round, you will find a young man between the age of 15 and 40, experience insidious onset of intermittent or persistent low back pain and stiffness, better with physical activity. It's centered in the lumbosacral spine. There may be chest pain as well. There may be peripheral arthritis, and there may also be heel pain. What are the extraskeletal manifestations؟ احنا خلاص قلنا في المحاضرة وموجود عندكم في السايت. اما تدخلوا تبصوا على المحاضرة هتلاقوا ايه الكلام ده برضو كله موجود. Extraskeletal manifestations include cardiac manifestations, ascending aortitis, kidney ممكن يحصل secondary amyloidosis or IgA nephropathy, acute anterior uveitis مهمة قوي. We never forget this is one of the common extraskeletal manifestations. Restrictive changes can occur in the lung, upper lobe fibrosis, and 30 to 60% may even have asymptomatic colitis. يعني أساساً ما يشتكيش, and when I do an endoscopy, I find it. So do not forget the acute anterior uveitis. Acute anterior uveitis. يبقى the clinical manifestations: inflammatory back pain, الimaging, الإكس-راي أو الMRI, الESR واللاب, with good response to non-steroidals. برضو ما ننساش الجينيتكس HLA-B27 could be positive and family history, وما ننساش أسأل about psoriasis, Crohn's والconcomitant infections اللي ممكن تحصل وتعمل urinary tract infections. في الفيزيكال examination أخذتوا أنتوا في الكلينيكال راوند, we have to do the tests to assess the spinal disease. We do the occiput to wall test to assess cervical range of motion. We also do the chest expansion, the Schober's test, and we look for the sacroiliac stress test, amongst which we have the most important, the lateral pelvic compression, the open book test, the Jensen's test, and the Patrick's test. يبقى دي اللي احنا بنتست for sacroiliac tenderness over the posterior superior iliac spine. برضو الشوبس تيست اللي احنا بناخد a point in between the posterior superior iliac spine. We measure 10 centimeters in a straight. When the patient is standing very straight, lend him bed forward. It should increase by 5. If it doesn't increase by 5 or more, then we have to know that there is limitation of the lumbar motion. Here is the occiput to wall test. This is the classical way that you have been taught in the clinical round. This is the lumbar flexion and the way we do it. This is if we do not pick up our patient early. This is how our patient it becomes, and he is very depressed because he cannot even pick up his head to see the wonderful sun that we have here in our country. So after we have taken the history and we have examined our patient, what are some of the tests that you should know as a clinical round? When I ask you what are some of the important tests that you do, you tell me, of course, I will do the HLA-B27 because I know it can be present in quite a large percentage of our patients. We do the routine function, tests, including the hematological tests. ممكن ألاقي anemia, ممكن ألاقي طبعا ال ESR وال CRP elevated. طبعا ال pulmonary function test, if my patient is advanced, he will get thoracic involvement and I will pick up a diminished vital capacity and total lung capacity, and at the same time طبعا he will have an increased residual volume and functional residual volume. طبعا زي ما احنا قلنا rheumatoid factor is negative. The x-rays هتاخدوها for radiology. I don't want you to worry about it a lot during the clinical round, but we do the sacroiliac joints. وطبعا في البداية ممكن نلاقي erosions حسب inflammation, pseudo widening of the joint, sclerosis, والبوني bridging ده مهم قوي of the joint, وcomplete loss of the space. وبنعمل بعد كده MRI وممكن أحيانا بنعمل السياتي. اهو الاكس راي شايفينه اللي هو هنا فيه ايه sacroiliitis, narrowing of the joint spaces, of complete obliteration of the sacroiliac joint, واللمبر spines برضو فيها squaring و loss of the bone mass. طبعا shifting on to the treatment, what is our treatment management? How do we manage our patients? If I ask you in the clinical round after you have examined your patient, what will you do for your patient? You will tell me that my aim is to control the pain. As I told you, these people are usually quite miserable. They have not only back pain that is chronic every day. They can have chest pain because of the central joint that is affected, the manubrosternal joint, the costovertebral joints. They also have heel pain. They may also get uh, 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 um, pain due to the peripheral arthritis. So the pain is from many sources. So you have to control the pain. You have to maintain maximal skeletal mobility. We have to tell our patients you have to keep moving. You can't stop moving, because if you stop moving, the inflammation increases and it gets worse, and you will be completely ankylosed. And we have to treat early, because, as I said in the lecture, the earlier you treat, the better will be the results, and you will prevent deformities. So, what are the lines? Physical therapy. Never forget that patients should be enrolled into a physiotherapy program. He should maintain an erect posture, because this is very critical, and you should tell him the way he should sit. Stand up as straight as possible. They won't be 100%, but as straight as possible. He should walk as much as possible. What are the drugs that we have to relieve the pain and the inflammation, so that we can preserve the posture and help him to do the exercises? Non-steroidal anti-inflammatory drugs are the cornerstone of therapy. The easiest and the simplest drug to use, and the cheapest, is endomethacin. We use endomethacin in quite a large dose, 25 to 50 milligrams, 3 to 4 times daily. This is the most commonly prescribed drug that we have, and we have to prescribe it early to control the inflammation and to control the pain. We can use any non-steroidal anti-inflammatory drug. There's a very big list. You should know 2 to 3. We can use ibuprofen. We can use the COX-2 inhibitors. There's a very big list. When we have peripheral arthritis, as I showed you in the picture, then we can use sulfasalazine or methotrexate. But if there is only axial involvement, sulfasalazine and methotrexate has no value. It has proven to be of no use. So we don't use it. We only use sulfasalazine and methotrexate in peripheral arthritis. So immunosuppressive drugs, as I said, methotrexate is used only in the peripheral arthritis. We almost never use steroids. Axial systemic lupus with rheumatoid arthritis. Never use steroids, because we know that our patients get osteoporosis and they are liable to fractures. Except in certain situations, if he gets an acute flare, either in his joints or in his eyes, an acute flare of steroids, then we have to use steroids for a very limited time. If he gets a systemic manifestation, then we have to use steroids, but only for a limited time. So you as undergraduates should know this very well, that systemic steroids are almost never used, or used with extreme caution in ankylosing or in axial spondyloarthritis. We may sometimes use intra-articular corticosteroids. This is useful if we have one single joint that is very, very painful and very resistant to treatment. And of course, now, for the past 2 decades, we also have our biological therapies. In the pathogenesis, when we spoke about it, we said that there is a lot of pro-inflammatory cytokines, and among the pro-inflammatory cytokines is the tumor necrosis factor alpha. So now we have tumor necrosis factor alpha inhibitors, and we also have another very important drug, interleukin 17 inhibitors, because they also discovered that interleukin 17 is one of the very important cytokines that leads to continuous enthesitis and arthritis and spondyloarthritis. And now we have these 2 very good biological agents that we can use to control inflammation. And by this, I end this very concise and simple way of approach to a case having a clinical approach of a patient having axial spondyloarthritis. What I want you to know as undergraduates, when you have any patient presenting to you with low back pain. There are many causes of low back pain, but if he tells you that the low back pain is chronic, what do we mean by chronic? We ask you in the clinical round, what is chronic? Chronic is more than or equal to 3 months. زي ما قلنا في rheumatoid arthritis. What is the duration? It's more than or equal to 6 weeks. Here in axial arthritis or axial spondyloarthritis, the low back pain, which is the commonest complaint, it has to be more than or equal to 3 months. And usually the individual is less than 40 to 45 years of age. Immediately, if you have these two clinical findings, then you have to ask about the chronic low back pain. Is it inflammatory or non-inflammatory? But you have to ask him, is the low back pain of a gradual onset or of an acute onset? Is it progressive? Does the pain become aggravated when you are inactive? Does it become better when you exercise? Is it associated with nocturnal pain? يعني بتقوم بالليل قرب الفجر and you have to walk around because you are in severe pain? Is it associated with morning stiffness? And what is the duration of the morning stiffness? فيها neurological complications عشان النيورولوجيكال احنا عارفين اكتر بالميكانيكال، والبين ده بيسمع في رجليك، لو بيسمع بينزل below the knee. If it's below the knee, most probably it's mechanical. If it's above the knee and the buttock is affected, then it's inflammatory. So this is the most important things that you have to ask. And after you have said that it is inflammatory low back pain, we do not forget to ask about the extra articular manifestations. The eye. What about the eyes? Do you have any redness in your eyes? Have you had any blurring of vision? Because I have to exclude acute anterior uveitis, conjunctivitis. Do you get chest pain that could be also due to, for example, aortitis, dyspnea? Is there any low limb edema? That could be that he has amyloidosis due to the chronicity of the ankylosing spondylitis. And we have to pick up our patients early. Once we identify our patient as having axial spondyloarthritis, then you have to do your imaging. We do a plain X-ray, we do an MRI, we do the HLA-B27, ESR, CRP, and afterwards we manage our patient, as I said. So this is what I want you to take from the clinical round. Fatma Mohammed had just entered now, and this is what we say, Fatma Mohammed has entered بعد الفرح مخلص. Okay? Okay. Are there any questions related to this clinical approach? The lecture you will find in full on the YouTube, in the site that I have given you, and the clinical approach you will find in great details under the OSCE section in the e-learning of the students, which is available freely for all our students to see. Are there any clinical questions? Go under the area which is the 6th year students. That's where you will find your lectures as well. أي أسئلة؟
بعد إذنك يا دكتور.
اتفضلي. اسمك ايه يا دكتورة؟ ازيك يا أستاذة دكتورة فتحية؟ اتفضلي. تمام. بالضبط. الله ينور عليكي، الله ينور عليكي. عشان يعني انتوا طلبة بكالوريوس أو سنة ثالثة. What you need to know is what the tests I gave you. If انتوا you need to know 4 tests. I will not ask you other than 4 tests. ال 4 tests لو انت تلاحظي انا ما جبت سيرة الموديفايد جينلز تيست. انا لا انتوا في الراوند بتاخدوا كتير، انا فاهمه، بس انتوا كطلبه يعني لو انت كطلبه بكالوريوس هتقولي لي الاوبن بوك تيست واللاترال بيلفيك كومبريشن والجينسلنز تيست والباتريكس تيست، انا هقول لك سلام عليكم يا دكتوره 10 على 10. يعني الموديفايد جينسلنز تيست في ناس كتيره اتشالت خالص من الكوريكولم، ما بنقولهاش عشان this is too technical وفيها a lot of fallacies. you need to know the Gensler's test. لو تعرفي الجنسلس تيست هقول لك شكرا يا دكتوره فتحيه، الله ينور عليك. اوكي؟ so don't bother، يعني ما تدوشيش دماغك. لو تعرفيه 4 tests 3 tests هقول لك شكرا يا دكتوره. you understand؟ ماشي. في حد تاني معانا؟